questions we just brought up.
So thank you once again, everybody, and thank you for the wonderful invitation. Onno's a great friend, colleague, collaborator. Our thoughts should go to him and his family as they've had bereavement, and it's my great pleasure and true responsibility to stand in this place
per talk, including discussion. So I'm going to ring very much. Okay.
So this is an unusual meeting because MRI has been mentioned more times than PSA so far, which represents a real sea change in our focus of attention. And there are a few things that have been mentioned that are worth highlighting before we go into the details. And the first is that MRI is a multifaceted test. It can do different things, and just because you don't believe it can do one of the things, it might do one of the other things very well. What this talk is about, and I didn't choose the title, it was given to me yesterday, is about the positive predictive value of MRI. So in other words, what happens when you see a lesion in the same way as what happens when you see a lesion on mammography? How do you respond to that lesion? This is about decision to biopsy and about targeting. This isn't about the negative test or the normal test, which in most cases we use to avoid a biopsy, mammography, liver ultrasound, renal CT. And that is another question that I'm not going to address. But in population terms, in terms of MRI as a triage test that follows PSA, it's the negative predictive value that probably has the greatest importance. The other thing about MRI, and we've just seen elements of it, is that it generates lots of emotion. And I think there are many reasons for that that are worth highlighting. I think there is genuine frustration amongst clinicians who want to do good MRIs that they don't have the facilities to do it, the reimbursement opportunity, or indeed radiologists that can deliver the quality of scans that they want. Some of that's about the manufacturing of the equipment, some of it's about the way in which the equipment's set up, and some of it's about the motivation of the radiologist. And that I can understand. And there are also big turf issues and great concerns amongst urologists about losing the front end of our most common disease. And also we were talking in the car today, coming here, that once a patient has his MRI, he has all the information with him in the disc in his pocket. He can then choose to go and get opinions from whoever he wishes to go and see, and can use this information, which is empowering, to negotiate the next steps. And I think the one way to disenfranchise patients and to lose patients is to not become an expert in this area. And this is all about adding value to the pathway by us becoming real experts in interpreting the signal that MRI is giving us. And I think that's very important. So it's nothing to be afraid of. This is something we can master just like we mastered CT scanning, just like we mastered ultrasound, and we can be the custodians of it and confer the real value on patients for the future. So this is about the positive predictive value. This is not about the negative scan. And I think it's just worth reflecting on the extent of the revolution that is in front of us, in that currently all trainees in Europe, all residents in the States are taught to spread their needles widely in the prostate in the assumption that the distribution of cancer is homogeneous in the peripheral zones of the prostate, because that's where you're going to get your yield. And this is what we tell our residents to do, and then we tell them to mirror it on the other side. And we're now becoming increasingly aware that, of course, the distributions of needles is not uniform, and the distribution of cancers is in places that these needles don't traditionally reach, midline, apex, and anterior parts of the prostate, and that this strategy, if you don't know where the tumor is, results in gaping holes in which very large tumors can be missed and never verified, and therefore the patient doesn't go to radical prostatectomy, and therefore the pathology doesn't sit in our archives, and therefore our natural history is skewed. And so the negative test is under-evaluated because it's never subjected to a formal reference test. So that's what we teach everybody to do. When you're looking over the shoulder of a trainee, that's what you're telling them to do. Of course, prostate cancer, we now know, is distributed throughout the gland in almost a random manner, and if you use that earlier strategy, you will not sample parts of the prostate and you will miss large components of tumor. So the future is a different one. It's the one all our colleagues do in all other solid organ cancer. And it's identifying an area of interest, of high probability, So in other words, not assuming that the probability is the same throughout the prostate, but assuming that the probability is high in a zone of the prostate. Most cancers occupy, at the time of diagnosis, about 0.5 to 1.3 cc's of tumor. They cannot be uniform throughout the prostate. They exist in a very small component of the volume of the gland. So we need a test that confers a high probability, positive predictive value, and obviously the converse of the test is that it confers a high negative predictive value. If it has a high probability of being somewhere, it has to have a low probability of being somewhere else. And the new challenge is actually not to spread your needles, it's actually to converge your needles as if you were shooting or firing an arrow. This is a skill we don't teach our trainees. And this is the modern skill, to sample the tumor so that the full heterogeneity of the gland is caught and available to histological analysis, to the new genetic testing that is available. And so the pathologist has not just one core, but several cores of that tumor with which to make a predictive diagnosis. What we do to the rest of the gland, we might be able to touch on in discussion, but will depend on the negative predictive value at the prostate level, which I'll touch on. So there are about, I think Laurie's got some papers that he will show you in more detail than this, but this is currently where we are in terms of the published literature. There are at least 4 or 5 papers that aren't quoted at the bottom here, from Japan, from West Coast USA, indeed increasing now from East Coast USA, from Hopkins, and also from NYU, UCLA as well, all showing roughly the same. So in terms of positive predictive value, 70 to 80%, there are some false positives. Inflammation and atrophy can be a false positive, and the lower your threshold for targeting, the greater your proportion of false positives. This allows you to apply judgment on who you biopsy and how many needles you choose to deploy. Ruling out prostate cancer, the negative predictive value of the test is really astonishingly high and remarkably stable across studies. And indeed, the most recent study from Notre Dame, the negative predictive value, and I'll show you the study in a minute, was 100%. So when the MRI was negative, no patients in this small study had any pattern 4 identified. And so these are the drivers, the accuracy rates that are telling us what constitutes an area of interest or high probability, and where indeed we should be sending those needles. This is what happens when you do a targeted biopsy. This is a case from early in February, and his PSA was 7.3. He had a very strong target, MRI 5 on 5. Our radiologist thought this was a 100% chance of being a prostate cancer, and would always constitute a target. All the sector biopsies, this was done transparently, were negative. The targeted sampling, which is a left lateral, 4+3, 5 of 7 cores positive, and a range of cancer core lengths and a range of distribution of Gleason scores to fully represent the heterogeneity of the gland. 1, 1, 2, 4, and 4. It's a very small lesion, about 0.3 cc's in volume. You can see now that if you target, you get a completely different type of risk stratification. You get multiplicity of cores, and you get much longer cancer core lengths, 2 of the drivers of risk that we currently use in our sampling. This is another case illustrating that MRI just cannot identify 1 millimeter of Gleason 3+3, probably its greatest attribute. It systematically overlooks that. And in the area where it's negative, it'll either be negative or you might stumble across microfocal disease. And you have to have some threshold of disease which you're quite happy to ignore and reassure the patient that this doesn't matter. And each one of you will be in a slightly different place on that. But again, the targeted cores, not as many cores positive, 3 of 7 cores positive, 4, 4, and 5 millimeters maximum cancer core length. And you can see the percentages there. So you can see how different the conversation would be with a patient had you had standard biopsies versus, i.e., you're clear, sir, when indeed he wasn't. And in the second case, higher burden of disease, maybe higher risk disease than you would have had if you'd just done the non-targeted cores. So you identify very different populations. What MRI does confer to us is something that we've been blind to for about a century, since Hugh Hampton-Young did the first radical prostatectomy, and that's tumor location. And we've treated men so far without any evidence or indeed information on tumor location. So all our treatments are based at the gland, whether it's be radiotherapy or surgery. Our biopsies are a threshold decision of whether to treat. They're not informed by where the cancer is. And so if location is a new variable, and I would argue quite an important one, a bit like being a liver surgeon, a bit like being a kidney surgeon, that actually knowing where the tumor is changes what you do to the organ, then we need a nomenclature and a language to communicate location succinctly and precisely to each other. And this is just one suggestion that was derived in a consensus meeting, and some of you were at that meeting just to try and give us some kind of language that we can use to communicate location. These are all men that came to our unit and had, because they had several, usually, transrectal blinded biopsies, so in other words, no MRI beforehand, which then subsequently proved to be negative. And this is the kind of situation that you see. This is T2. There's a coronal image there and an axial image. You can see a large T2 lesion. And it was just a little bit high, and obviously the transrectal biopsies missed it because the operator didn't know where it was and was biopsying randomly. Here's another one, midline tumor. The midline isn't sampled, as we know. We send our cores to the left and we send them to the right, but we don't send them to the midline. These cancers shouldn't occur. There aren't any ducts in the midline, but they do. This proved to be a 4+3 cancer. I think this man had 2 or 3 negative biopsies beforehand. These are the worrying ones. Here's a large T3A anterior tumor. This man had 3 negative biopsies before he was finally diagnosed. And this is how bad it gets. The whole transition zone of the prostate completely replaced by tumor. And this man had had, I think, 4 or 5 actually biopsies beforehand, with a PSA originally around 4. And by the time we saw him, it was around 15. And he's probably now incurable. As you can see, the cancer invading the anterior stroma at the front of the prostate. So this is what location gives you. It just tells you where to fire the needle. And I think the question is whether this is sufficient for us and whether it confers value in terms of representativeness, more precise risk stratification, and subsequent better treatment allocation, or whether we need help to get our needles into the right place. This is a study that was published now a couple of years ago. This is me doing it and using as a reference standard 5mm template sampling. So in other words, it's the only reference test you can apply to all patients. Obviously, you can't do radical prostatectomy on patients that test negative, but you can sample them at 5mm. And this really tests just how good sampling is versus firing a needle throughout the prostate blind to location. And this is an example, this is an extreme example, just to demonstrate the issue. His tumor is up there. This is a large prostate, measures about 60 to 70 cc's in volume. You can see that most of the prostate comprises of transition zone. He could have had many, many, many rounds of transrectal biopsies. He would have tested negative. His biopsies, you can see there, all the non-targeted were negative, supporting the negative predictive value of the MRI, and the positive area at 12 o'clock was positive in 2 out of 5 cores. Most missed it. Maximum cancer core length 1 and 4 millimeters, 3+4, and the 4 component occupied 20% of all the cancer. So you can get really great precision on the Gleason grade distribution within the lesion, which hopefully will be useful in the future. And this just shows you the kind of sampling efficiency that's possible by knowing where the cancer is. And this is the same study. This is comparing targeted, which had 900 cores in all in this cohort versus 7,000 cores, 5 cores per patient versus 30 cores per patient, 1 core per 10 cc's versus 1 core per cc. This is the difference in sampling density. And you can see already that the number of cores positive was greater, or the proportion of cores positive was greater for the targeted sampling, 38 versus just over 10% for the non-targeting. This is what you do. So the sampling efficiency, assuming equivalence, and I'll show you what this cohort came out with. So in other words, targeting a few needles to the lesion versus sampling the whole prostate blind to the lesion. The first thing to notice is the extraordinary high detection rate. So if I do your biopsy, you have an 80% chance of having prostate cancer versus all the other proportions. We've seen a lot of proportions so far in the in the populations described so far. This is an extraordinarily high population. But the important figure here is the 64% that have clinically significant disease. And this is not because all the men that we see have clinically significant disease. We're using MRI in order to select a group that are more likely to have clinically significant prostate cancer. The average proportion or rate of clinically significant disease in a trust biopsy population is between 5 and 15%. This is a dramatically different population from those that have been historically described and represents, I think, the future of the kind of cohorts that we're going to see. In terms of the yield, so targeted biopsies, 103 clinically significant and 17 clinically insignificant. And template biopsy, 113 clinically significant, but twice as many clinically insignificant. So targeting is as good as, statistically, as doing lots of cores, and what it does do is halve the proportion of men that are given a diagnosis of insignificant disease. So one thing better than doing active surveillance on men that don't need to be treated is not to diagnose them at all. An MRI does give you an opportunity to do that. The other thing about sampling in a targeted manner, in other words, bunching the needles rather than separating the needles, is that it gives you very different pathology and it will make everybody look high risk. So this is what happens when you sample somebody and you don't know where the cancer is. You probably miss it. If you do hit it, you're unlikely to get a direct hit just because of probability, and you will get a yield that is unrepresentative of the tumor burden, hence the upgrading. When people say they have upgrading, that is a measure of the error of their risk stratification at biopsy. One's upgrading should be 0, and indeed targeted sampling has a net downgrading, for reasons I'll explain in a minute, of around 5%, whereas most trust biopsy series have a net upgrading at radical prostatectomy of between 30 and 50%. That means that between a third and a half of the patients received an incorrect risk stratification after the biopsy that was corrected by removing the prostate. I would suggest that that is unacceptable now, and we should be aiming for a 95% concordance between the risk stratification conferred to the patient at the time of diagnosis and indeed the verification at surgery. What happens if you target this? Well, you oversample deliberately, and that middle needle oversampled the Gleason 4+4 component and not the other bits. Obviously, you'll get a range of Gleason scores throughout, but your eye will be focused upon the single core in the middle that contains Gleason 8 on its own. The overall will be 4+3, but your eye will be taken by that core in the middle that holds Gleason 4+4 and is 100% of the core presented to you. This is the same patient. You've just approached them differently, and you've yielded different information that will make you behave, I'm sure, very, very differently. So we just need to be very aware of how we're going to absorb and accommodate this workup bias as a result of this more precise risk stratification. This is what happens when you do trust biopsies and targeted biopsies. This is modeled on radical prostatectomies that have been digitalized and subjected to 2 forms. These are the same patients, but you can see the distribution of number of cores positive and the cancer core length vary. Number of cores positive and cancer core length are both drivers of clinical risk in most of the models that we traditionally use. And so the error we could make is to overestimate their risk, whereas traditionally we have underestimated their risk. I think this is getting fairly mature now. I mean, I think there are many groups around the world doing it. There are at least 15 comparative studies that compare image-guided approach to some other non-image-guided approach. And this has been summarized for you in a systematic review, and many of the authors of this review are in the room today. And I think the evidence for me, and I wrote it in the editorial to Siddiqui's paper, is overwhelming, that targeted biopsy is better than non-targeted biopsy. And if you believe that, then you have to try and derive a target before you stick a needle in the patient. The other issue about whether a negative scan can be used to avoid a biopsy, I think, requires a little bit more work. But I think that's the issue. What we did recognize after that was that the reporting was hugely problematic in that people were reporting the outcome of targeted biopsies in a number of different ways, which made interpreting the literature very, very difficult. And again, many of you who are in New York are here today, and we sat down and thrashed out many of the issues and came up with this, which I think has been helpful. And many of the papers that have been published recently are conforming to these kind of standards of reporting and conduct, which I think will help make more sense of the literature in the future. There are many ways to target, and the list is there, and I don't think I'm going to go through it in great detail, but essentially it's whether just knowing roughly where the tumor is sufficient, because if we take what we've been arguing today, we should only really be biopsying decent-sized tumors, and they're not that difficult to hit, as I've illustrated, or whether we need to invest in equipment that costs lots of money and helps us get us there. And I think that's the big debate at the moment. There are many companies out there that will be happy to help you do your targeting. This is a Canadian one. This is a Dutch one. This is a Israeli one. This is a UK one. This is our own. And just illustrates how we might go forward in the future, in that a man who wants to be evaluated might choose to go and have a decent MRI from an accredited center, may not even come to urologists in the first place. That MRI will be contoured at the prostate level and at the cancer level, and that information will be sent up to the cloud or given to a disk put in his pocket, and he will take that to somebody he thinks can make sense of it. If you can't do targeted biopsies, he is unlikely to come to see you. This information can be worked with, computed, can be rendered in all kinds of ways. It can be used and entered into all kinds of targeting systems. And you can see now that the MRI information can then be inserted into the ultrasound information in any office around the world. Anybody can pull this down. And the MRI can automatically find its way into the ultrasound machine, as you can see here, initiating and registering in an automatic fashion, so that the operator, for the first time, and this could be any of you in your office, you do the ultrasound, you do the registration, you find the area of interest actually embedded on your ultrasound picture, which will allow you to place your needle directly into it, both in the X and Y, but also, more importantly, in the Z coordinate, to help you. I'm sure this is coming. There are many companies out there now. None are quite perfect, but I'm sure this will become a very standard thing when we meet, possibly in 2 years' time. There's a lot of activity in this area. The Siddiqui paper has been mentioned already. This is looking at fusion biopsy versus 12-core biopsy. This is done from the NIH, from Peter Pinto's group. So basically, you have an MRI. You have to have your MRI before your biopsy. That is segmented. In other words, somebody draws around the prostate, somebody draws around the tumor. That MRI information is then transferred to the ultrasound at the time of the biopsy, and then in this study, you did standard transrectal ultrasounds. Somebody was blinded to the location of the tumor, and then somebody else came in and did some targeted sampling.
Mark, we need to finish up.
Okay, well, I'll stop with this one then. And this just shows you the kind of yield that you get. So if you are interested in identifying high-risk disease, then you should do a targeted biopsy. If you're interested in identifying low-risk disease, then you should do random biopsies. And this shows just how it plays out. And so over on the left, you see the Gleason 8s that were missed by 12-core biopsy versus those that were missed by targeting. Targeting, because MRI is positively associated with volume and grade, it finds it very, very easy to identify high-grade disease. It systematically overlooks low-grade disease, and I think this is probably a very good slide on which to end, and I think will tell us that the goodness lies in that direction, and that will come through imaging, no matter what biomarkers do, because biomarkers will never, ever give us location. Thank you very much.
Mark, thank you. In the interest of time, we're going to have Laurie